The laws that are designed to eliminate abortion and make it really hard to get are making more later abortions. So, I think this exposes the hypocrisy of the anti-abortion folks. Because we left gaps in the narrative, they got filled in with bullshit and dangerous bullshit. And this was stuff that was really just made up by the anti-abortion side because there wasn't anybody talking about it on our side. They put flyers in all the mailboxes and in the mailboxes of the neighborhood and on the cars, like all around campus. And it was basically a flyer that had our pictures on it, our address, an email address, and then a picture of like fetal tissue that they had stolen from another clinic.
4 years ago, the Supreme Court issued its decision in Dobbs v. Jackson Women's Health Organization. This was the decision that repealed Roe v. Wade and effectively criminalized abortion in many states around the country. Of course, abortion rights and reproductive health have been in the crosshairs of the right since at least the early 1970s. Today, I sit with Dr. Diane Joy Horvath. She's an OBGYN who runs one of the very few clinics and centers around the country that perform third trimester abortion care. Diane talks to us about these procedures, about her patients, and how she ended up dedicating her career to reproductive health and abortion care. Take a listen.
So let's get down to it. Late-term abortion, third trimester abortion, these are probably the biggest flashpoints that we see all the time in anti-abortion propaganda that anti-abortion activists use all the time. What is late-term abortion?
So a slight verbiage correction. So the late term actually refers to the end of a pregnancy that goes beyond the due date. So when we talk about abortion later in pregnancy, we say later abortion or abortion later in pregnancy. I think having the term in there has become kind of an inflammatory thing because people have in their imaginations that someone waltzes in off the street at 40 weeks and decides that they no longer wish to be pregnant and they come in and have an abortion. And we know that that's not the case. We know that people are here for all the same reasons that they're getting abortions early in pregnancy, and also because of barriers that we've put in place to getting abortions earlier in pregnancy. So I think, we know that even among people who consider themselves pro-choice or consider themselves supportive of abortion rights, they're very, very uncomfortable with later abortion. And so that's kind of what we're up against when we talk about this with the public. Mm-hmm.
And in one interview you had before, you talked about how almost you gave a hypothetical that's also very realistic of how can a person become needing later abortion. Yeah. So walk us through this.
Yeah, we think about this in terms of kind of two big groups of people who need this care. One group of people get new information in the pregnancy. So this could be a fetal diagnosis, which certainly we see people with bad fetal diagnosis that was discovered very late in the pregnancy. Could be a maternal health condition. So the pregnant person has now discovered something about their health that they didn't know before that necessitates ending the pregnancy. Or it could be things like, I had a patient once whose house burnt down midway through the pregnancy. She had a bunch of other kids. There was no shelter that could take them all at one time. And she just said, I can't have a baby right now. And I think that's new information, right? Mm-hmm. Finding out that your house burnt down. Yeah. And also late discovery of pregnancy is actually a much more common piece of new information than I think people can appreciate. Most people find out that they're pregnant early on in the pregnancy, usually, by 6 to 8 weeks, but there is a significant proportion of people who don't know for lots of really good reasons. Maybe they're very young, maybe they don't have regular menstrual cycles, maybe they were told, and this happens all the time, by somebody, oh, you're going to have trouble getting pregnant. And of course, they didn't recognize any of the signs or symptoms that they had as pregnancy related. Some people have no pregnancy symptoms and they don't get nauseated, they don't have any of those other things we think about in pregnancy, and then they only find out very late because they come in for some other reason and someone says, oh my gosh, you're pregnant. And so new information is one kind of group of people. A second group of people are people that knew they were pregnant, wanted an abortion, and ran into significant barriers. And these are all human created. So these are all things like bans on insurance coverage, bans in a state or in all the states around it. So sometimes it's a complete abortion ban, sometimes it's a gestational duration ban, which necessitates travel. And so now you have cost barriers, you have childcare maybe this person needs, because we know that more than half of our patients are already parenting at least one child. There might be barriers related to social stigma, barriers related to being a young person. And obviously this group of people intersects with the other group. So sometimes you get new information and also experience barriers. And so those are the two main ways people get to us.
Let's walk through like a hypothetical timeline.
Yeah.
So, and let's maybe start with just like the barriers, not the late information. So, when most people know that they are pregnant, and if they are living in Texas,
Sure,
or in
yep.
so let's try to imagine a timeline. Walk us through it.
Yeah, absolutely. So you are kind of your average 25-year-old in Texas. You find out you're pregnant at maybe 8-9 weeks pregnant. That's a completely normal time to find out. You obviously can't get an abortion in Texas except under extremely limited circumstances. Like you have to be pretty much actively dying. And even then it's questionable whether or not the hospital's lawyers will let you have the abortion you need. So you basically can't get it in Texas. Maybe you know about abortion pills by mail and maybe you don't. And maybe you just don't want to do that. You want a procedure. You want to know when you walk out of the clinic that you're done and that your pregnancy is ended. So you do some looking around online and maybe you find out that you can go to, for example, Kansas to have an abortion. But by the time you're able to raise funds, so now you're maybe 15 weeks, 16 weeks, you're looking for money, you don't have any money, maybe you don't have transportation. There is a law in Texas criminalizing aiding and abetting an abortion. And so you feel like you don't want to necessarily tell your best friend because you don't want her to get in trouble for aiding and abetting if you were to get caught. There are places in Texas that have debated laws to prevent people from driving through their county to get an abortion. And so there's some like fear there. Also imagine you are an undocumented person and now you have to think about, can I get on a plane? Like, am I going to have the ID I need? Am I going to get pulled off of a Greyhound bus? And so maybe private automobile is your only way to do this. And so I don't know that people really understand the kinds of things that our patients are bumping up against. We see a lot of undocumented folks that were fearful to leave where they lived because they're fearful to go to school at this point or go to the grocery store. So maybe now it's 20 weeks and because only, maybe 10 or 12 weeks after you discovered you were pregnant and decided you needed an abortion, but it's taken you this long to get all these resources together. Maybe you've saved enough money and then you get to Kansas and you find out you're actually 2 weeks later and now you're too far for the clinic that you went to. And now you have to go back to Texas. You have to raise more money and you have to find out where you can go now. So maybe you identify that you can go to Illinois, but that's another, 12 hours drive. And now it's another 3 or 4 days off of work because now you're in a multi-day procedure that you'll need to have a hotel and you'll need to have food and you'll need to have all kinds of support to get you there. And luckily there's organizations that help with things like that. But if you don't know about them, it's like they don't exist. And so, maybe by the time you get to Chicago, where the clinic is that can see you, to 34 weeks, now you're 28, 29 weeks. It seems like such a long period of time, but there's no point in time in this pregnancy where the pregnancy stops growing, right? So all these weeks that pass, you are getting more and more pregnant and getting further and further away from being able to get this care because by the time you hit 29 weeks, there's only a handful of places in the country where you can go.
Yeah. And I mean, when you think about it, it takes weeks to prepare even like a vacation trip.
For sure. And that's fun, and you're motivated and not that people aren't motivated to have their abortions that they need, but like real life bumps up against all this stuff. Like, if you live in Texas, it's not like you can just tell your employer, hey, I'm going to be gone for 5 days so I can have my 3rd trimester abortion. Like that's just not a reality for people to be able to tell people that. And the other thing is sometimes by then people look pregnant. And so you're maybe concealing a pregnancy from your family, maybe concealing it from your job, maybe from an abusive partner. So our patients are running into, I mean, this is real life for people. Even if you have a perfectly supportive community and a perfectly supportive family, this is still really tough care to get.
So in a way we can say, we have, you have patients who have to go through later abortions or third trimester abortions because of all this new information, because of diagnoses, because of, issues of disease or genetics, etc. But there are another group that our laws and our politics are literally making this a necessity at this point.
And I think, we've had this kind of narrative that if people use birth control, then we won't need abortion. And that's not true, because we know that there are new information, things that happen even in a very wanted pregnancy and a very planned pregnancy. Also, birth control doesn't work all the time. People can be perfect users and still have failures. That's a totally normal thing. But I think, the other big reality about this is that the laws that are designed to eliminate abortion and make it really hard to get are making more later abortions. So, I think this exposes the hypocrisy of the anti-abortion folks. This isn't about reducing the number of later abortions. This is not about, making people more likely to be supported enough to feel that they can have a baby or another baby. This is about making this care difficult to get, and it actually paradoxically makes it more likely to happen.
And in a way, you're pushed on the early end with all of these things, right. And then ultimately you're pushed into the later end, where it is politically, a flashpoint where it's essentially used to demonize the entire case.
100%. And we have done ourselves a disservice as a movement by saying things like, 90% of abortions happen in the first trimester. Yeah, that's true. But the reasons that people need abortions later in pregnancy are really important. And those patients are often the most vulnerable. They have the most difficulty accessing care historically. They're often young. They lean towards very young people. They're folks that are, have social issues in their own lives. They use drugs. Maybe they are living in poverty. There's all kinds of reasons that are modifiable that we have done to make this care a lot more likely to happen. And it needs to be preserved for those reasons.
Yeah. So, okay, let's switch gears a little bit. Let's jump into the time machine. And we are now in 2002 in Minnesota. And you're a young doctor thinking, I think at this time, probably ending your residency or finishing it.
So 2006, I started my residency.
Okay.
Yeah.
So 2006, you're, and now you make a decision to go into OBGYN, but also to just focus all your work on abortion care and contraception. What happened?
Yeah, I think that I had an origin story, I think, that started probably with Catholic social teaching. So I blame the nuns for teaching me that people needed to be actively loved and cared for. And sometimes that means taking care of them with abortion care. I grew up Catholic. I went to Catholic school all the way up through high school. I definitely considered myself anti-abortion, at least in high school. I was never an activist, but I also had very strong feelings that how sad this was and how terrible abortion shouldn't be needed and all of these other things. But I think that, going to college, I took a women's studies class, which is the beginning of the end for many of us, that was the door that opened. And I thought more about, why do people need this? And what situations do people find themselves in? And how does it look to meet those people with compassion instead of judgment? And in a perfect world, would we have perfect diagnostics and everyone would have enough money to buy food and support the families that they have? That's great. That's not the world that we live in. And so how do you show up for people when we don't have perfection around them? And I thought a lot about it. I actually had a conversation, one of the things that radicalized me was having a conversation with my grandmother, who was a nurse in World War II era. She had seen all the things. And I did a survey. She was this Lutheran lady that lived in central Wisconsin, rural, evangelical Lutheran. And I had to do a survey for this women's studies class. And I asked her about various social issues. And when I got to abortion, I said, how do you feel about abortion? And she goes, well, I think it should absolutely be legal, especially in the first trimester. And we can't have people dying trying to end their pregnancies. And I was like, like blown away. This is never anything that my mother had talked to me about, nothing that my grandmother had ever talked about, but she saw the impact of lack of access to care, to safe care. And she took care of people who were dying from septic abortions. And that's just unacceptable. It's nearly 100% preventable. And she knew that. And so that actually made me think a lot about where I was and the privilege that I had grown up with to not ever have to, have seen any of this. And so that changed me. And I became really involved in pro-choice activism in college. And then when I got to medical school, I actually started the chapter with a couple of other people of Medical Students for Choice at my medical school. We had a chapter of Medical Students for Life there, but they had not had a Medical Students for Choice chapter. Mm-hmm. And so I remember the first time I got a death threat, and that was in medical school from starting a chapter of Medical Students for Choice in Toledo, Ohio. And that just made me even more determined that we needed to do this. And then when I was choosing residencies, I really liked the mix in OBGYN of surgical skills and then like kind of primary care, like being with people, having some longitudinal relationships with patients, and also acute care. Like it's basically acute care for pregnant people. And I looked specifically for programs that had abortion training integrated into the program. Like I didn't want to have to go somewhere where it was like, oh, you can do it on an elective, because that's really difficult. And I found out later that it's much harder than I even thought it would be. And watching now, taking learners from other places where it's like they have this elective time, but they have to find their own funding, they have to find their own travel money. I'm really glad that I ended up where I did, because it was part of my curriculum. And as I learned more about it, and I did my elective in abortion care when I was there, so I got to train up a little further than my classmates did. It just became so clear to me that this occupied a really important space in reproductive health care. It's just as important as birth care. It's the same people who are having births. It's the same people who have miscarriages, the same people who need contraception, the same people who need menopause care later in life. It's not any different from any of those other things. And so that was kind of, I decided I was going to do it as part of my practice. And so when I was a generalist for 4 years, I did hysterectomies and attended births and did all the things. And I also worked at Planned Parenthood on Thursday nights as like my side hustle. And so that became the most like the favorite part of my job. Mm-hmm. And I realized that there are always going to be people who want to do C-sections at 3:00 in the morning, and always going to be people who want to do hysterectomies. But if I didn't do like particularly later abortion, and I didn't teach other people to do it, I didn't know if it was going to be around. A lot of the abortion providers at the time were older, and they were looking to retire, as they should. And I thought, this is not going to be here if we don't do it. And I kept, I kept saying things to myself like, this is great that this is available, and I'm glad someone else does it. And then I got to the point where I was like, I can't not do it, because I have the skill set, I have the will to do it and the heart to do it. Like, I can't keep saying other people should do it. And that's actually how I got into all-trimester care, was like, it's so great that someone does this. And then when I was confronted with the opportunity to do it, and I did it, it was very clear to me that this was something that I needed to be involved in for the rest of my career.
This is, you just mentioned something really, really important. There will always be somebody who's willing to do a 3 a.m. C-section, and that's important, and it's super important. But it also, I think you're highlighting this important space that abortion care occupies in the larger landscape of OBGYN. Tell us a little bit more about this. I mean, how, it is often presented as this kind of tiny niche thing that, we need just a couple of people to do it and it's not a big deal. Yeah. But your experience, that's not the case.
Well, we know that 1 in 4 women in the United States will have an abortion by the time they're 45. And we don't have any data on trans and non-binary and genderqueer folks, so I can't speak to that. But we also see patients that are trans and non-binary in the clinic, so we know those folks have abortions too. This is something that we have siloed a little bit as a community, and I think it's tough because there's a tension between the fact that most abortions don't have to happen in a hospital. They're extraordinarily low risk. They're much, much safer than continuing a pregnancy and having a birth at any point in the pregnancy. And early in the pregnancy, they're safer than running a marathon. They're safer than getting a colonoscopy by a lot. They're safer than getting your wisdom teeth pulled in terms of mortality risk. So very safe procedure, doesn't have to be in a hospital, shouldn't be in a hospital from a cost perspective. However, because we've now pulled it out of hospitals, hospitals, except for the sickest patients, we've run into two things. We're out in clinics that people can just not pay attention to and can say like, well, it's different because it's in a clinic and it's outpatient and it's not in a hospital, so it's not legitimate. So I think it has inadvertently delegitimized the position of abortion within the larger medical care community. It's also exposed us to risk and violence. It's a lot harder to attack a hospital or to threaten a hospital than it is to threaten a freestanding clinic like mine. And so I think it's put us in a position where we've been vulnerable to attacks that I don't think would have been tolerated had we been in a multi-specialty group, because, people are, we don't hear about people attacking dermatology offices, and they shouldn't, but they shouldn't be attacking us either. I also think it's created the problem of now these hospitals do not think that this care is their problem or their responsibility. And so an example that we run into quite a lot is that we have a patient who comes to see us and they're so sick, like they have preeclampsia, which is high blood pressure at the end of pregnancy, and it's so severe, it's life-threatening, that I can't actually put them on a plane back to Texas or Louisiana or Missouri because it's too risky. Like they could have a stroke and die on the plane. I also can't take care of them in the outpatient setting. So we can sometimes induce fetal demise. So we can have this person show up to the hospital with what would be a stillbirth. But the hospitals in our area, many of them, not all of them, but many of them will not take our patients, even if they come with a demise, which is something that hospitals take care of every day. And I think it is because hospital lawyers are super risk averse and they misread the law in Maryland. We don't have a gestational limit in Maryland. We don't have a viability ban. They could take care of these patients and they don't. We've got a wonderful relationship with one of the hospitals in DC where I did my fellowship, but very disappointing lack of participation or lack of support from some of the other hospitals in Maryland.
Mm-hmm, mm-hmm. And just add to this all the difficulties for training practitioners. So
for sure.
So you alluded to this a little bit about the difference between, what you needed to do when you were training and what people, so somebody, if you're starting your career and you want to do the same thing today, how different is it?
So a lot of places that used to offer abortion care or offered it as like an elective that was built in and you could opt out or opt in or whatever, a lot of them now are in states where the state legislature has banned state funding from going to abortion training. And so those places are not able to offer that training anymore, or they have to find private funding to send you someplace else to have that training. So I had it built into my program. The other place that I looked at that was like my top few also had it built into the program, but then lost that training years later when the state flipped to red. And so that, had I been there at the time when that happened, it's very possible that we would have lost the ability to have that training. And 1 in 4 women has this care in their lifetime. It is unconscionable that you could get through an OBGYN residency and not know how to do this. It's also a really important thing to note that doing induced abortions helps prepare you and give you surgical skills to take care of pregnancy loss. So this is the exact same procedure that we do for people who lose pregnancies. The place where this becomes really important is in the 2nd and 3rd trimester. If you don't know how to do a 2nd trimester dilation and evacuation procedure because you've never done induced abortions, you're not going to get the volume you need to be good at it so that you can take care of that person who rolls in the middle of the night bleeding and needs this procedure emergently. So the fact that this is not available in so many places now as a training opportunity is actually harmful to patients, because you do have to have, it's like I haven't done a hysterectomy in 10 years. I would not do one on a patient now because I don't do them. I know how to do it. I mean, I could still tell you the steps of doing it, but I haven't done one in so long. It's not safe for me to do that on my own without having practiced it with someone else, like another surgeon cooperating with me. It's not safe for someone who only does 1 D&E a year, dilation and evacuation a year, to take care of a patient. Like, you have to have the volume to stay good at this. Mm-hmm. And it's a risk to patients when we don't provide people with this training.
You're raising really important points. It's not, there is a ripple effect of what we're doing that results in, a lot of significant problems, and that has negative effects not only on the 1 in 4 patients who need abortion, which is not little. Yes. This is huge.
Yes.
This is 1/4 of that's not little, and right. And on its own, it's huge. Yes. but also the other 3 patients.
Right. Right. Or the same patient who had an abortion and now is having a pregnancy loss, or who has a pregnancy loss and then goes on to need an abortion later in life. Like, these are, this is as normal and as common as birth care. And I will also say that, the birth care system in this country needs a lot of work, and women's health and reproductive health in general is underfunded, undervalued, under-reimbursed. We're in a better place than we were 10 years ago, but we are still in not a very good place. We have incredible disparities that persist in outcomes between, Black and white birthing people. This is part of a bigger problem with the undervaluing and the under-resourcing of reproductive health care. But the fact that, someone could get out of a residency and not ever have done an induced abortion or have done 2 or 3 dilation and evacuation procedures, you need to do hundreds of them to get really good at it, especially the complex ones. And those are the ones that are going to roll in the middle of the night into the emergency department.
Right. I'm going to stay with your journey, the early journey, a little bit. And, any young practitioner, any, resident or fellow early, there is always, for many people, there's always this kind of moment, if you will, or maybe a couple of them, that just you encounter a particular case, you're in a particular situation, and then it all clicks. It's like, this is why I'm doing what I'm doing.
Yep.
So did you have something like this?
I've had a lot of moments. I'll talk about 2 of them, because one happened early. I did in medical school between the first and the second year, I did a reproductive health externship with Medical Students for Choice, which I want to shout out. They're a wonderful organization. They are helping make abortion providers possible. So that was formative for me to have done this externship. I spent a month at the Madison Abortion Clinic in Madison, Wisconsin, back before Madison became a red state. I think we're moving in a good direction again there, but, and they provided abortions up to 24 weeks. And they had me in the first week I was there, I just did counseling with patients. So I did patient education. I listened to people's stories. I learned how to talk people through the process. And that was when I met that patient whose house had burnt down. And it had never even occurred to me that would be something, people's houses burn down and, people have massive loss, but to think what does it actually mean to bring a newborn into a situation like that? And I actually had been staying with my cousin who had a baby. She was 21. She had a baby that earlier that year. And so I was living with a young person who had a baby and watching kind of her parent and what resource that takes and how much of her time it took. And I was not a parent at the time. And really thinking about what would it be like to have a newborn in a shelter, and thinking that's not something I would want to do either. And what kind of sacrifice this person was making to say I really wanted this pregnancy, I wanted this baby, and I can't imagine doing this right now. And it's better for my children that I have already. It's better for me to be healthy and to be able to figure out how to get us back into a home before I have another baby. And that kind of selflessness. And I think we see abortion framed as selfish. And if it's selfish to prioritize your children that you already have and your family's well-being, then cool, maybe I'm all for it. That's fine. So that was a big eye opener. And I also took care of a patient who did not have capacity to make the decision. She was somebody with severe developmental delay and had been obviously assaulted because she was not able to give consent. And that experience of what it looked like to counsel her with her parent and get her assent, and also have the parents watch her parents be heartbroken and also resolved, and trying to assess the patient's understanding. It just made me think a lot about how complex medical decision making is, and how this does not belong in the hands of a government official. That decision belonged where it was made, in the clinic with the medical providers and the family and the patient, and how I could not possibly explain the nuances of that enough to make a law that respected all of the difficult things that went into that decision. So that was a big radicalizing moment. I was like, oh, this cannot happen in the halls of a legislature. They just don't get it. And then a second time, this was later in my career when I was working at a different all-trimester clinic, and I took care of a patient who was very young. And she had traveled from the South, and she was, I think she was early 3rd trimester, and we did her procedure, and she was kind of stoic, and I didn't, understand when you're very young, this is a totally overwhelming experience. It's overwhelming for older people too. So I just thought this is pretty appropriate for like a young person to just not be as talkative maybe. And she had her procedure safely. She was the last patient there that night. And her mom came into the recovery room with her because there were no other patients left. And so we were chatting, and the mom was talking about how proud she was of her daughter, and like she's going to go back and play sports, and she missed this season, but she's going to come on this season. And the patient was kind of just sitting listening. And I turned to her and I said, "What are you looking forward to when you go back home?" And she looked at me and said, "I kind of just want to be a kid again. You know what I mean?" And I said, "I think I know what you mean." And I had to go to my office and cry because, like she was going back to middle school. And this was hopefully an experience that would just kind of fold into the fabric of, who she is and what she has experienced, but that she gets to go back and be a kid. And what a sacred thing to be able to provide that opportunity for somebody. And I do feel like, having grown up Catholic, I'm no longer religious, I'm atheist, but the moments where I feel the most spiritually connected to the universe, to other people, to a life energy or anything like that, are these moments with patients where they let me into their lives in a really profound way. And I'll also say that I want to acknowledge that it is very common, even among people who consider themselves pro-choice or pro-abortion or supportive of access to care, to be uncomfortable with the idea of later abortion. And I want to acknowledge that that's a valid feeling. I don't actually need people to be comfortable with this. I need people to understand what they don't understand. And what they don't understand is what it feels like to need this care, or to be sitting across from somebody who tells you that they are going to harm themselves, or that this will ruin their life if they're not able to get this abortion, or they're a child. And we can all look and say, this is going to complicate this young person's life in a way that isn't acceptable if they determine that for themselves it's not acceptable. And so I am hopeful that we can hold the tension of feeling uncomfortable with the idea of later abortion with the resolve that this care is important and needs to be preserved for the people that need it most.
That takes us to thinking about some of the politics of abortion. And, May 2nd, 22, we have this report leaked in Politico about the majority opinion on the Supreme Court. You don't really need to spend too much time reading to know they are overturning Roe v. Wade. Yeah. So where are you at the time and what happens? So
kind of ironically, I was at a meeting of the National Abortion Federation, which is one of our annual conferences. And it was the last night of the meeting. Everything had wrapped up. Everybody was feeling good. We were in Florida, and I was sitting at a table at dinner with 3 of the other people who work in the clinic. And we were getting ready to order, and a text pinged to people's phones, like a headline, like mine was a New York Times headline. And you could hear the restaurant go silent. And everybody looked at it. We kind of looked at each other. And then all of a sudden, it was like, oh my God. And one of the people at our table who worked with us at the time was a nurse who was from Texas. And she started to cry, and she said, people are going to fucking die. People are going to die, and I don't even know what to do, and I need to go. And she went back up to her room to be devastated. And I think there wasn't any illusion when the case was being argued that this was a possibility. This obviously was a possibility. And I think the people who were surprised by it were not paying attention, and they were not listening to reproductive justice advocates. They were not listening to Black people. They were not listening to healthcare providers or to patient advocates, because we knew that this was a possibility. And it was the culmination of 50 years of strategy by the anti-abortion forces. This is not by accident that we ended up here. But it was still a devastating thing to read. And it was also just wild that it happened to be when we're at this meeting where it's it's so many people from so many clinics all over the country, from other countries, come to this meeting. It's this annual gathering. And to have it happen there was it was devastating.
Mm-hmm. Mm-hmm. You said, I want to go back to the 50 years of strategy.
Yeah.
You're right. This wasn't a new thing.
Sure.
So how do you evaluate the pro-abortion or pro-choice politics on that side for these 50 years?
I'm not a policy expert. I'm not a lawyer, but I hang out with a lot of lawyers. I'm a lawyer admirer. And I think that some of the problem that we've had is that the anti-abortion folks know how to pull at heartstrings. And we've come at this from a rights-based approach where it was like everyone has the right to bodily autonomy, which is absolutely true. And I will die on that hill. And also, it's not as emotionally compelling as talking about babies and talking about, we're harming babies. And there's, there's still billboards everywhere. Like when you drive through, I drove to Ohio a few weeks ago to see my family, and it's like we passed, half a dozen anti-abortion billboards on the trip over, and they all have babies on them, obviously. And I think we didn't come at this from the kind of values-based, discussion that we should have been. We should have been talking about the space that abortion occupies in people's lives and how this is the same people that are having abortions as are having births. And, I think we were afraid of getting into some of the nuance. It was abortion on demand without apologies, which I personally believe in. Mm-hmm. And I also know that that doesn't resonate with people emotionally because emotionally it doesn't feel real to a lot of folks. I am not here to convince the people on the far right who are standing outside of clinics or issuing threats. Those are not the people that I'm talking to. I'm also not talking to the people that are firmly on our side that are shouting their abortion. Those are all really important people in our movement. They're great. And this message isn't for them necessarily. There are a lot of people who are in this middle where they maybe are okay with abortion early in pregnancy or they're uncomfortable, but they're willing to kind of let that go. And when we get a little bit more complex, it gets to be, the fetus now starts to be more than just a liminal kind of thing. It's now we think about it as a developing baby. We were afraid to use the word baby, even when patients were using it. It's no, I use the word patients used. And the way I talk about abortion with the media, the way I talk about it with public is the same way I talk about it with patients. I want people to know that there isn't anything shady going on in the clinic. Everything I'm telling a patient is what I'm telling you. And if a patient calls it their baby, that's what I call it because that's the patient's to decide. I want people to be able to hold complex thoughts at once. So the complexity of being maybe uncomfortable personally, or maybe I personally would never do this. Okay, fine. You've maybe never been in that position, or maybe you have and you chose not to, and that's fine. But also you maybe wouldn't tell anybody else what to do with their own lives. And when we talk about shared values, we talk about things like being able to decide on your own healthcare, knowing what's best for your own family. That's something that actually cuts across political divides. And I don't think we spend enough time leaning into those kinds of messages and talking about we don't need to anticipate guardrails. For example, we don't need to put a ballot initiative in a constitutional amendment question that establishes a viability ban. Because when you talk about values, you talk about being able to make your own healthcare decisions, that extends across the whole pregnancy. And actually, when some very smart friends and researchers that I know ask this question, the language that removed all viability language, when they asked people, would you support a constitutional amendment, de-restricting abortion across pregnancy? When the viability language was gone, people actually supported it more because the message of being able to make your own healthcare decisions, it's at what point in the pregnancy does the government know more than you do about your healthcare? And when we asked it that way, people were well, never. Well, of course I wouldn't want to have the government telling me at some point that I couldn't make a decision about my own body. And I don't know that we've been willing to be uncomfortable in these discussions. And I am very willing to be uncomfortable. And I would think that the more we're willing to have those difficult discussions, the more support we will get.
Mm-hmm. Mm-hmm. So this takes us to the point you mentioned earlier about how we need to talk about abortion and talk about abortion also as a personal experience. Mm-hmm. So So say a little bit more about this. Why is it important to talk about abortion? I mentioned in the beginning that your clinic is one of the few that has the A word in the actual name.
Yeah.
A lot of places, and for good reasons, do not want to do that.
Yeah. And that was on purpose. We wanted to be very clear that that is what we do here and that we're proud of providing this service because it is a necessary part of reproductive health care. I think that so much about abortion has been shrouded in mystery and shadows, and we didn't talk about it, I think, honestly, as a movement. And because we left gaps in the narrative, they got filled in with bullshit and dangerous bullshit. And this was stuff that was really just made up by the anti-abortion side because there wasn't anybody talking about it on our side. And I think specifically about later care, specifically about what later care entails. An example of this is that I was doing, I did a year fellowship in reproductive health advocacy after I finished my family planning fellowship. So I worked for Physicians for Reproductive Health for a year, and I just did advocacy. This was the election year. So this was in 2016. And then the months following, so 2016 into 2017. And I was told, because we were an advocacy organization and a 501c3, like I couldn't electioneer, and I had to be really careful about how I talked about this. But I was told when people asked about later abortion, I had to say things like, these comments don't reflect medical reality, which is true, but it also isn't super satisfying. And I think I understand how sound bites get pulled out and misused, but I think that we have appeared evasive in the past. Yeah. And I think that that's done us a disservice. Medical care can be gross. I would not want an orthopedic surgeon to graphically talk through the steps of a knee replacement. It's disgusting. There's saws and hammers and it's gross, right? I've scrubbed into those cases as a med student. And nobody wants the kind of details of all of this. But I think that an orthopedic surgeon isn't ashamed to talk about the steps of a knee replacement. And we should not be ashamed to talk about, in broad terms, the steps of a later abortion because it is medical care. It's also different from early abortion. And I think that's another thing that has been a problem that we have had as a movement is that patients don't experience later abortion in the same way that they experience an 8-week abortion. It's just not the same. They don't have to travel sometimes 5 or 6 states away. They don't have to come up with thousands of dollars. They don't have to, they're not visibly pregnant. People aren't asking them when they're due. And they're also not necessarily looking at the pregnancy remains in the same way. I mean, we offer all of our patients keepsakes for their pregnancies. So we offer people, and this is at every gestation, we offer things like ultrasound photos if people want to see them. Later in pregnancy, we offer people things like fetal footprints. We offer the ability to hold the baby, hold the remains, and to take home a memory box, with a blanket and a hat and things like that. And we offer that to people regardless of the reason they're there. So there are folks that are ending this pregnancy because it is mistimed. It's with the wrong person. It's with a dangerous person. It's, they didn't want another kid right now. They don't want another kid. They don't want a kid ever. And I am always it is profound to see people take us up on the offer to view the remains, even if this was not a wanted pregnancy that went wrong. People have a connection to their pregnancies that I think we don't allow people the space to have. I think we sometimes talk about how people should be only 5% of people regret their abortion. Okay, but you can have lots of complex feelings that are not regret. You can be sad, you can be angry, some people are joyful that they get to start their life again. And we have not made space in our movement in the past for all of those feelings. And I think one of the great things about some of the storytelling organizations like We Testify is that they are making space for that. And they're holding complexity and modeling the way to have a space for someone to say, I really hated the fact that I needed to have an abortion and I wish I didn't have to have it. Okay, that's really valid. There's a lot of people that we see that wish they didn't have to be there. But they're there because they need it and because that's the decision they're making with the best available information. And not everybody is happy about their abortion, and that's okay. But not everybody is sad either, and that's also okay.
And I think this idea of storytelling and holding space for patients and how they talk about it is really important, because at the end of the day, there are a lot of people, like you said, it's 1 in 4 people
Right.
will have an abortion.
Yeah.
And so almost everybody knows somebody who went, or they themselves.
Yeah, or they maybe they don't know it, but they do.
Yes.
You know somebody, and
Yes.
you love somebody that has had an abortion for sure.
Yeah.
Yeah.
And if you're limiting the ability of people to talk about abortion in their own words, you're essentially, pushing them out of the space where they can talk about their experience.
Absolutely. And I think that it also, when we talk about this publicly, and when I have, it's always the question, like if I'm on a plane and someone says, oh, what do you do? Or I'm like working on a presentation on my laptop and, oh, what's that? It's that moment where you're like, do I tell them what I do? Is this going to be like a super uncomfortable 3-hour flight? And sometimes I test the waters a little. It depends on how much time I have or how tired I am or whatever. But sometimes I'll say I'm an OBGYN and, I have a clinic and, oh, that's so great. What does your clinic do? And then sometimes I'll say we're an abortion clinic. We take care of folks later in pregnancy who need abortions. And I will say that sometimes people are uncomfortable. And if there's going to be somebody uncomfortable, it's going to be them, not me. I've been through this discussion a lot of times. So have a nice flight. But a lot of times people are like, wow, or they ask great questions, or they tell me they had an abortion, or their sister needed a later abortion because there was something wrong with the baby or whatever. This is an experience actually that ties people together. And we don't make space to do that. I also think that having open discussions about the complexities of abortion and the space that it occupies in people's lives opens up a discussion about other reproductive outcomes and the complexities of those. There is not a place for people to talk about having regretted having children.
Yeah.
And that is talk about a stigmatized group of people, and a place every time I see a post on Reddit about somebody who regrets having a child, it's just God, that is, we expect people to be uniformly happy about parenting, and people aren't. Yeah. And I think the more we're able to open up a discussion about the complexities of abortion, or even just the hard parts of adoption, that's another discussion that absolutely is not happening in a way that it should be. People talk about adoption like it is some panacea, well, we don't need abortion because we have adoption. Adoption is not an alternative to pregnancy, right? It's an alternative to parenting, and it has a lot of problems. And I think when we center adoptee voices, we see that it is much more complicated than we are being told to think it is.
So you mentioned a little bit earlier the moment when you Googled yourself and found a photo of you and your kid. Can you tell us a little bit more about this and about what it is like, these things in the life of an abortion care provider?
Yeah. I remember it was an August evening and I had the windows open and my child was not a great sleeper. And so we were up watching The Wire and hoping she would fall asleep. And I was just you know what? I haven't Googled myself in a long time. And I didn't know then about Google Alerts, which I've now set up. So I know right away when something's out there, which is really important, I think, for folks who work in any kind of public space to do, my plug for setting up a Google Alert with your name. But I remember just this sinking feeling oh, and I knew about this website already. And I knew that friends of mine were on it, and I knew that I would end up on it probably. But the fact that they chose that photo was a pretty hard gut punch.
A photo of you
and my child. Yeah. I mean, they had, I said, they had ones from my job, fine, whatever, be jerks. But this was beyond the pale. And I had thought a fair amount about safety because I had been working at Planned Parenthood when I was out in practice, but I was also in an area, I was in Minnesota, I was in the Twin Cities, and it's a pretty supportive community. And we had lots of protesters at that Planned Parenthood, but I had a parking spot on the roof and the escorts would push people out of the driveway to get, let you in and stuff. And it just became part of the fabric of doing the work. And I think there is a risk to normalizing that kind of intrusion into your professional life, into your personal life. It's not normal. It's really fucked up. It's not normal. Nobody should have this be a part of their job or their life, worried that the neighbors are going to get mailings in their mailboxes. When we moved into this space, before we had even opened, an anti-abortion group who they have a real big crush on us. They put flyers out into not only all of the buildings in our complex, which we're in a complex with like a couple of dentists and some lawyers and some like computer repair places and an acupuncturist. It's just like a general kind of office complex. They put flyers in all the mailboxes and in the mailboxes of the neighborhood and on the cars, like all around campus. And it was basically a flyer that had our pictures on it, our address, an email address, and then a picture of like fetal tissue that they had stolen from another clinic. This was like a big thing that happened a few years ago. One of the activists was found to have like the remains of like, they stole remains off of the back of a medical waste truck. So
wow.
They claimed that the person gave them to him. I don't know that I believe that, but, and then basically said something like, we're here so that college girls can have all the fun they want and not have one of these to deal with. And I was like, well, yeah, kind of. I mean, like, sure, like that's also fine, like totally okay. And the wild thing that happened was that they totally misjudged our community. So our complex, we got a couple of notes from people in the complex, like thanking us for being there, excited we were there. A lawyer in the complex said, I bet your patients are dealing with some really hard stuff. Like if you ever need legal advice, like just give a call up. Like, wow. A few of the neighborhood folks, like there's faculty and staff and students that live in this neighborhood. But we got a couple of notes from people that were like, we had no idea you're here. This is great. And like, where can we send a donation? A few of the people on like the neighborhood next door group, like got all of their Ring camera footage together and gave it to the FBI of people because this is putting like threatening things in a mailbox, which is illegal.
Yeah.
And then on the campus, like a couple of the professors reached out and they were like, oh, this is such a great resource. Thank you so much. Like, glad to know you're here. And so I think it backfired for them because that got us kind of an in the community. Yeah. Like, and also to like have, people say, wow, they're already bullying this clinic. They just got here. They're not even open yet. That's ridiculous. We also made a connection at that time with the pro-choice student group on campus, their RJ group. And we went to we brought stuff to they had a slut walk the first year we were open, and we went and did the slut walk in our scrubs and met people and brought stuff and gave away swag, and then came to speak at a couple of their events. And then there was another episode where the same group stickered the campus with another sticker with fetus pictures on it. And so I went around in a 1.5 block radius and took down something like 25 stickers in 1.5 blocks. They were everywhere. And so we reached out to our campus allies and we said, this is what's going on. If you see these stickers, could you just pull them off when you see them? And they said, great, yeah, no problem. And probably 3 hours later, they sent us a photograph of a sticker ball the size of a basketball. Oh, so they had gone through the entire campus and taken down every single sticker that they saw. And so that is what community means. Mm-hmm. And we also have noticed now in keeping track of where our patients are coming from, that we are a community clinic for this area. So when we do have folks that come from locally, particularly for our earlier in pregnancy patients, it's a 10 zip code radius. We are a community clinic now. Mm-hmm. People get on the bus to get to us. People walk to get to us. And this was also really important to us, knowing that we're taking people from out of state, sometimes out of the country, but also we're a resource for people who live up the road.
Yeah. Yeah. And this is what everybody should have.
Yeah,
the capacity to just take a short bus ride.
Absolutely. And a place that people are going to respect them and meet them where they're at and, have culturally appropriate care, be affirming. Mm-hmm. And I love that people, I actually love when people come back for a second abortion. So we've been open long enough now where there are folks that are coming back to see us for their second abortions. And, sometimes they're oh, I feel really bad about being here. And I was hey, we're here for you however many times you need us. Mm-hmm. And we're really flattered that you came back. Thank you. Yeah. That's a huge compliment to us. Or someone will bring their cousin and be well, I had my abortion here. I told my cousin and she's going to come now. It's okay, awesome.
Yeah. I mean, there's something really beautiful about the idea of how we need to normalize just another aspect of reproductive care that should be just like any other part of really any medical care, reproductive or otherwise.
Yeah. It always kind of blows my mind when people leave a Google review with their real name. And I'm oh, okay. And then I was but also cool.
Yeah.
Good.
Yeah.
More people need to do this.
Yeah. Yeah. So when we're thinking about abortion care politics, there is also the idea that abortion care and reproductive health in general is not, it is definitely a women's health issue and a women's rights issue, but it also has all of these other things that are related to race and class. And
Absolutely.
So tell us a little bit about this. What do you think about this, about the different dimensions of reproductive care and abortion care?
Yeah. I mean, I think this is where the pro-choice framework has failed us, and where it's not getting at all of the things that go into making a decision about reproduction, whether it's, to continue a pregnancy and birth, and where to birth and under what circumstances and with what kind of birth attendant, or, is it the decision to get your fibroids treated, when we know that fibroids affect Black women and Black folks more than white folks, and they're under-researched and underfunded and all of those things. I think reproductive justice is the lens that allows us to come at all of these things and the ways that they intersect. And I will also say, I am not a reproductive justice activist or, practitioner. That's a lane of our movement that, I use to inform what we do. Obviously, reproductive justice belongs to Black women and the people that created it. But it is a really powerful framework to be able to look at rights and health and be able to say, what does choice mean if you don't have any money? And what does choice mean if your kids aren't in a safe school and you can't even take a day off of your, low wage job to go take care of your own healthcare because you've used up all of your sick time taking care of your kids? I think that it informs those other lanes. I see 3 parallel lanes. There's reproductive health, which I would put myself into reproductive health because I think that, I'm a healthcare provider. I run a clinic, so I have some administrative things and executive things, but I am first and foremost a physician, and can speak to health expertise. I am one of the people that holds some of the expertise about later care. There's also the rights folks, and they're really important too, because we do have to move these cases through the courts, and we do have to have good legislation, and there need to be really smart people working from the rights side and the policy side. And then there's the reproductive justice, who are working to help us all see this from a more holistic view than I got pregnant, I didn't want to be pregnant, I made a decision, and then I did the thing. It's there's so much more to accessing healthcare and to actualizing your own reproductive life plans than that.
And it affects, and again, as you mentioned several times, it has this kind of ripple effect on people's lives.
Oh, 100%.
That just, extends beyond this.
Yeah, there's something called the Turnaway study that is a really important piece of research and has spawned dozens and dozens of fantastic papers. What it was a study that looked at folks who were at the gestational limit or near the gestational limit for the place that they were going for their abortion. And it looked at people who were able to access their needed abortion and people who were turned away. So the name Turnaway study. And it followed those people for years afterwards. And it looked at multiple outcomes. So economics, the welfare and the health of their subsequent children and their existing children, educational attainment, ability to leave an abusive partnership, their own health, their ongoing health. And what they found was, totally unsurprisingly, being turned away when you needed an abortion, especially when you were at a gestational duration that you couldn't get it someplace else, was associated with terrible outcomes. You were less likely to leave an abusive partner. The kids that you have were less likely to be healthy. You yourself were less likely to have good health outcomes. You were less likely to have educational attainment that you wanted. You were less likely to be able to have advancement in your job. It is striking. And I think another really important thing about it is, in the past, a lot of the abortion outcomes research was comparing people who went on to have a baby that they wanted. So they were comparing people who had abortions with people who had a pregnancy without any kind of indication that this was a pregnancy that wasn't something that they wanted to continue. And so, of course, those outcomes are going to be not comparable. That's the wrong control group. And so this set up the correct control group. And it was affirmed what we all knew, which was that abortion allows people the opportunity to live the lives that they need to live.
So our podcast is called Vital Signs, and I don't have to explain vital signs to you. So, but at the end of every episode, we ask about vital signs, and we think about it, basically in 2 ways. One is in almost an quasi-medical way. So what are the vital signs on this issue, on the issue of reproductive health or abortion care, the things that we all need to pay attention to that gives us an indication of where things are going?
Yeah. I think that we should be looking at, the overall pregnancy-related morbidity and mortality and what that does in places that have abortion bans. What do those numbers look like? We should be paying attention to these cases that are coming out of states where people are being forced to have C-sections against their will. Just the recent news about the two women, I think it was Florida, who were basically ordered by judges on a Zoom call during labor to have C-sections against their will when they decline to have them. That is a huge barometer for how we view pregnant people's rights and autonomy and bodies. And that intersects completely with abortion care. Like if we're at a point now where we're ordering people to have major abdominal surgery against their will for the potential life of a fetus while putting at risk the life of the pregnant person, that is a big bad sign. And that I think paying attention to not just abortion care and abortion access, but the remainder of pregnancy care, the remainder of care for like gender affirming care for trans folks, trans children, like this is it's all connected. It's all part of the same like government intrusion into people's personal decisions about their healthcare. So that's a big thing. I would also say looking at the way that we treat the most marginalized people that need abortions. So like the youngest people, the people with disabilities, the people who don't speak English, the people who are undocumented, like that should be the gold. Like if we can't lift up the people that are our movement can't even lift up the people that need this care the most, that is a problem. So I think paying attention to how we talk about access for those people and for people who need abortions later in pregnancy.
Mm-hmm. Mm-hmm. The other way we think about vital signs is almost like road signs. So here, vital signs as important road signs. Mm-hmm. Where should we go, in your opinion? What is the direction for progressive politics, for left politics on the issue of abortion?
I think we need to stop shouting at each other from like the hilltops with the giant chasm in the middle. We have the place where movement is going to be made is not on the far right or the far left. The movement has happened in those spots. People are dug in. The place to make movement is in the middle, and it's something called the adjacent possible. Mm-hmm. So I did not go from being a Catholic school girl in Cleveland, Ohio, to running an all-trimester abortion clinic overnight. I thought differently about who might need abortions and what compassion looks like. And then I talked to my grandmother, and then I took a women's studies class, and then I decided that I wanted to do, medical students for choice group at my medical school. And then I went to a residency that had abortion training, and then I expanded my gestational capacity. Those were all steps. Like we cannot expect people to get from a place of like really deep discomfort to being like, rah, rah, abortion. Everybody should get one who wants it for any reason all the time. I would love for people to get there, but we know that's not how human brains work. Yeah. And so I think that the road sign for me is, the systems change starts with individual change and helping people hold and manage their feelings about abortion and modeling how you can do that in a way that isn't stigmatizing and that isn't shaming. Like I think it's wonderful when somebody says to me, I'm really uncomfortable with later abortion. Okay, like talk to me about that. Mm-hmm. Like tell me more about that. What makes you uncomfortable about it? What questions can I answer for you about the way we provide care? Like I think that, being able to acknowledge that everybody feels differently about this, but maybe we can all get to a point where we're at least letting people make their own decisions. We don't have to feel good necessarily. I don't need you to feel good. I just need you to get out of the way so that people can make the decisions that are best for their own lives. Mm-hmm.
Diane, thank you so much for sitting with us, and thank you so much for all the work that you're doing every day. It is such a privilege to talk with you and to hear about your experience and your work. Thank you so much.
Thank you.
Thanks for joining us. I hope you learned as much as I did. Don't forget to like, subscribe, and share, and make sure to join our Patreon for exclusive content that you don't want to miss. The conversation continues on the Vital Signs Substack, Instagram, and Facebook page. Let us know your thoughts in the comments and any impact this conversation may have on your thinking. See you next time.